So before we move down, so I think we sort of talked a great deal about this. Uh, would you ever, in any other circumstances, order this test? Let's say if the breast cell thickness is 0.8, let's say, right, transacted at the base or something like this. Would you order it, or at this point you still basically says you would
Yeah,
not?
I just don't I just don't have, I don't have any experience or from looking at the literature to say that it really would make a difference. My
Okay.
approach, I have different clinical approaches for these other scenarios. So if someone who comes to me with a transected melanoma, or let's say I biopsy a lesion that I don't think is a melanoma, and so I think it's a non-melanoma skin cancer, and so I'm not trying to do a deeper biopsy. I just get the top of it. It comes back as melanoma. Then I bring the patient back in and I re-biopsy again. And then there's studies showing that you can look at the second biopsy and decide whether that was the extent of the first biopsy, accurately showed the extent of the tumor. And then you could decide what to do. So I think there are workarounds for some of these things that you don't need to rely on a test like a GEP to help you make a decision like that. But as you said earlier, there are these 3% of patients with very early stage disease who do recur, and because early stage melanomas are so common, they actually represent about a third of melanoma deaths. So if we really could precisely identify those patients, that would be great, and maybe we could make a dent in that mortality number. But right now, it's not clear that the GEP tests can do that.
So the bottom line, this is a very promising future, and at this moment that we don't have enough data, and hopefully down the road, as science progress and research gets refined, and we hopefully can use it in clinical practice with much
I would
better.
just say as a final comment that, these tests were generally developed to predict metastasis, specifically distant metastasis. But I think the more immediate application is going to be, as we've said, prediction of positive sentinel node.
Yeah.
And there, I think, the clinical studies can be more easily interpreted because the sentinel node is either positive or negative at the time you test it. Whereas you never really know if the patient is going to have metastasis or not, no matter how long you follow them up, because they could still recur 20 years later. And so you never really know. Whereas I think for a sentinel node, you know what the result is. And so if you look at enough patients and enough GEP tests, you'll be able to really see how well do they predict that. And so, maybe maybe 5 years from now, we'll be doing that more routinely to guide us to hopefully spare more patients from getting the sentinel node rather than triggering the procedure. Because as you said also, most sentinel node procedures have a negative result. So we know that a lot of those patients actually didn't need that procedure, but we just don't know
Which one exactly?
Trying to figure out which ones. Yeah.
And I think your assessment is in line with the NCCN guideline, right? And I think also the AAD guideline is basically saying the GEP testing is not part of the mandatory, like, recommended workup at this
So
moment.
what's happened is the guidelines say a couple things. One, they say that you should use that there are multiple. Well, they first say that you should treat your patients based on their risk. And then secondly, they say that there are multiple ways to assess the risk, including GEP testing. But what they don't do is link those together, which some of the companies have done in their marketing, and say that the guidelines recommend that you use the testing for patient management. And so that third piece hasn't really been, substantiated yet, in my opinion.